So welcome back to SAS21. I'd like to welcome some new panelists and welcome back Chris Groombridge. So the new panelists are Jane Torrey, who's an anaesthetist, Kirsten Fraser, who's an anaesthetic technician and chair of the New Zealand Anaesthetic Technicians Society, and Claire Hayes Bradley, who is an anaesthetist and pre-hospital physician. Thanks for joining us, guys. So airway management is a team sport. We've heard that before already this morning. All members, not just the airway operator, are integral to safe and effective airway management. So what teamwork skills are crucial to airway management and how do we teach them? We're going to discuss how we can organise and optimise team training with reference to both pre-hospital programmes and in-hospital training programmes. So some of the problems we've identified as a panel: there's an increasing recognition of the importance of non-technical skills or human factors, but there may be a failure to recognise how deeply they're intertwined with the technical skills.
Charlie!
Hello? Sorry, I just had someone shouting in my ear there. Non-technical skills have traditionally kind of been separated from technical skills and taught in isolation or as a kind of bolt-on to courses. The technical skills that we require for well-oiled team performance, such as task management, can therefore get neglected sometimes in team training. Non-technical skills are often taught also as a kind of voyage of discovery, often with simulation, rather than in a directed manner. And often different professions are trained separately, which is something that we have to iron out and stamp out, I should say. So the solutions that we've come up with: there should be equal emphasis on technical skills and non-technical skills, and they need to be taught together. We believe at least some components of non-technical skills can be taught in a more directed, proscripted way, for example, giving clinicians a script or some key questions to ask in a crisis. I'm going to emphasize why training must be interprofessional. So we put out a poll last night. Some of you may have already voted, but if you haven't, here's a QR code for that poll. Please scan it and or go to the SurveyMonkey link there. Do you have access to regular interprofessional team training with your usual team? So in an intact team with people that you know that you usually work with, regular interprofessional team training. Do you have access to that? So yes, no question. It'll take you 5 seconds to do. So just follow that QR code and we'll have a look at that at the end of this section. So over to the panel now. Again, enough from me. Jane, you're involved with a really fantastic interprofessional training program known as Network Z, which involves simulation-based training for surgeons, anaesthetists, nurses, anaesthetic techs, and has recently expanded to include other professions like emergency physicians, intensive care physicians, paramedics, and even radiologists. How does Network Z address this fragmented approach to training that we've highlighted in the introduction?
Thanks very much for the opportunity. Yeah, networks, we don't want to overstep ourselves. We're only working on expanding outside ED, theatres, ED, and we're working on those other areas. The way we've approached that fragmented way is that the networks arose because it was seen as a gap in teaching teamwork and communication skills, and the premise was that improving those would improve patient outcomes and reduce treatment injury, in fact, in the operating room. And to teach a teamwork skills, you've got to be in the same place and all the team has to be together. So that was how it was approached. But it's interesting what you say about non-technical skills and technical, because the teams and networks, we're not trying to teach them technical skills. In fact, they are experienced all in their different areas. Although running a session with networks can give people insight into things that they've got decade skills in or need to brush up on, actually because they are already experienced skills in those elements, we're just trying to get them to focus on putting it together, which is the teamwork and communication aspect.
Yeah, I guess when I say technical skills in this context, I'm not talking about, laryngoscopy. I'm talking about intubation. So, the task of getting a patient intubated is a technical team task involving, equipment and somebody passing things at the right time and all of those things. So I guess that's what I mean by those technical task management type of skills.
Mm-hmm. Yeah, sure. So the approach was to settle on a model of teamwork, and have some really explicit things that were taught that right up front. These were this was the focus of the sessions, and the facilitators were trained to recognize and bring out those teamwork and communication aspects with very specific type of tools, for example, for communication.
Yeah, so you used this model called the Big Five, which is a publication by SAS from 2005, which I really loved. I think we've got a slide of that. How did you use this model to kind of design the course, and do you think there's been any kind of improvement in those aspects that you've noticed throughout the course of a day?
Right. So first of all, how we came settled on that one was from looking at what was going to be a useful model, and that really did look at teams as opposed to individual skills. So many of the things we might have been brought up in simulation, which are around crisis resource management skills, those are all really about individuals' skills, whereas this model looks at how the team functions. So how the team gets to get situational awareness in a shared mental model and so on like that. So we found a model that was built on a lot of empirical evidence across healthcare and other areas, and then used that and tried to keep it as simple as possible. Eduardo Salas has gone on to do a lot more work, but sometimes models become so complex they're hard to use. And we stuck with those elements, and then trained, I guess, our facilitators to recognise behaviours and where they fitted into that. Once you can name something and recognise it, you're far better able to teach it or perform it. So we wanted to give a name to some of these behaviours that are teamwork behaviours. As to how we know whether it's improving things, the very original pilot study back in about 2014, I think, which was not in situ and took 20 teams, real teams, from 2 local large hospitals, we were clearly able to show improvements in their teamwork behaviours over the course of the day. And furthermore, an initial look at teamwork behaviours back in their own workplaces was suggestive, certainly, that even having one person who'd been involved in a course like this for a day, it made a difference to how the team shared information back in the operating room. Changed the climate somehow.
That's a fantastic outcome. And one thing I really wanted to highlight about your program is that it's in situ in the actual environment where people work, and they're working in intact teams, and that you really design scenarios kind of bespoke for those teams, which I think is it's so learner focused. It's fantastic. So
Yeah.
moving on to Kirsten. Kirsten Janes highlighted some of the important elements of effective teams, like speaking up with concerns, anticipating needs, and this shared mental model, which we're going to come back to over again today. How does an anaesthetic technician training, how does your training address these issues? And how does an anaesthetic technician develop a relationship with their airway operator to ensure that there's smooth functioning of the team?
Thanks, John. Thanks for the question. Yes, absolutely. Like what Jane said is spot on, and it's crucial that those non-technical skills contribute to the patient outcome. As far as the training for anaesthetic technicians goes, because we're trained on the job, a lot of it is not directly learnt, but learnt by observation and over time. So as a mentor is teaching their trainee, you'll get the, like, what are you going to ask the anaesthetist next? What are you thinking about? And then you get the development onto then the trainees thinking for themselves and then interacting with the anaesthetist. And there's a lot of curious questions, which is kind of my favorite approach. The have you thought about, or what do I need to know? Those kind of getting the information in a non-threatening way so that your airway operator comes along for the ride with you, or you come along for the ride with them.
Yeah, that curiosity is great. That's a great standpoint to be, just tell me what you're thinking, that kind of thing. Do you have, as anaesthetic techs, you obviously work for the society. Do you get feedback from your members? Do they have access to kind of interprofessional team training?
So on the whole, no, it's not a scheduled or arranged thing. Many hospitals run their own simulation training. There's Networks, which is a national program, but by and large, resources, both human, time, finances, limit that in situ or simulation training, or actually any simulation training at all. So I don't think there's as much as would be ideal.
Yeah, right. Okay, well, we're going to come back to that a bit later on. So just very quickly, Kirsten, video laryngoscopy, does it improve your experience as an anaesthetic tech?
It does, and for those that have watched the rapid sequence presentation done by an anaesthetic technician called Dominic, it takes that experience from a me, i.e. the doctor performing the airway manoeuvre, to a we, so that everybody knows what's going on and can contribute equally.
Yeah, I really like that little video from Dominic. Everyone can see that online. It just explains why, from an anaesthetic assistant or an anaesthetic technician perspective, video laryngoscopy just improves things for them. And we're going to come back to that a little bit later as well. So Chris, you and I both run interprofessional airway courses, which are attended very much by ED and ICU nurses, who often find themselves in the role of airway assistant. During the pandemic, we held a specific training kind of boot camp for our ICU nurses in being an airway assistant for COVID intubations. And it struck me while we were doing it that we really should have been doing that all along, pre-pandemic as well. I know you've been thinking about this as well, and you've kind of coined the term Airway Ally. Can you explain what you mean by that and why you think a change in our approach to the out-of-theatre airway assistant is needed?
Yes, thanks, John. So the Airway Ally concept came about when I was actually working pre-hospitally. I noticed that I was much calmer in that setting, intubating patients, than coming back to the ED, despite all the backup. And I think the biggest difference in those two settings is that little team that you have. You have a great relationship with your paramedic, you've drilled together, you debrief the jobs together, and then if you get to a job, you discuss exactly how you're going to manage that patient that's in front of you. You're going to tailor your care to that patient. But in the ED, you could be forgiven for thinking that the airway nurse is just there passing equipment, and that's just such a waste of this experienced member of the team. And so what we've done is we've really rebranded it, and so we want to develop that role. You know, every intubation that occurs in the ED has the airway nurse there right next to you, and so it's such a useful role to develop. It's all about empowering that person to advocate for optimal preparation. So we find that the airway nurse runs the airway checklist, they mandate that it's been undertaken, they make sure that an airway plan has been verbalized to the room. They also do little things that make a big difference, like monitoring pre-oxygenation. If you're the airway doctor, but you're distracted, you want to help out, make suggestions and contribute to the rest of the resuscitation in the room, you might not concentrate on things like the mask seal. And so just by empowering that airway nurse who's always going to be there next to you to just say, hey, you really haven't got a good mask seal, you're not pre-oxygenating effectively, even little things like that has made a big difference. And so the rebranding has been effective, and it's really just changing the mindset so that they're not just standing there quietly passing equipment, they're actually fully engaged and trying to optimize, ensuring that optimization and preparation has occurred. I think that's been the biggest change. And again, as I said before, it is an opportunity to share a mental model and to share a bandwidth and to make it calmer for the people involved. And I have to agree with you actually that COVID has given us a great opportunity to practice these things. So we've done a lot more sims that includes the whole airway team. So since COVID, there's a lot more enthusiasm for those sims, and that's made a big difference as well.
Thanks. Yeah, I like the word rebranding there. It reminds me of what Louise was talking to us about earlier about naming issues, naming problems. And we've named this issue that we probably have neglected a bit, the training of our airway assistants in critical care, and maybe rebranding is the first step along the way to getting them credentialed in a way that is meaningful. So Claire, I really loved your talk. I was most impressed because you packed it into 6 minutes, which was the brief. All the rest of us completely ignored that brief and banged on for 20, but you did yours in 6. Your currency system, HEMS, so airway currencies and competencies. It feels like you've created this program that really combines technical and non-technical skills, which addresses a lot of the obstacles that we've been talking about today. What are the main features of the program that you think we could adopt in hospital medicine? And what advice would you give to our audience if they want to create a similar program to yours?
Interesting. Right. Yes. Morning. Hello, everyone. I suppose first is to sort of explain the term currency, because we're talking about essentially a team of two when we're managing the airway. We've got our critical care doctor, critical care paramedic working together. And both of those roles really get introduced during the induction. So the team already know kind of how we work. They're sort of skilled and drilled for that role. They know the equipment, the procedures, the checklist, the language, the patter that we refer to as how we talk to each other during an intubation. And so that's all established. And then there was this idea of, well, how do you keep that going? And in the aviation side, there's currencies that we have to fulfill for aviation requirements. So if you haven't done your static winch currency, you don't get to winch. And so we've already got this culture that we don't just get trained in a skill, but we need to keep current in it. And so that culture really has sort of come from the aviation side, snuck into the medical side. And we all think this is actually really sensible, really good idea. And so it becomes a part of pre-hospital and retrieval medicine sort of culture that every organization has this idea of currencies and refresher training and upkeep of skills. I think the fact that the computer reminds me it needs to be done is really helpful. When the computer's like, hey, Claire, your RSI currency's due. And I'm like, oh, yep, okay. Or it pings up again for advanced airway, which refers to the equipment we've got with D-blade, hyperangulated blade, the ambiscope flexible optic intubating system, and using those skills either as awake nasal intubation or a rescue intubation through an LMA with a fiberscope. And more recently, we've started also practicing the sort of the two-screen approach. And I'm not sure what the accepted acronyms and language is for that, but the idea of using the video laryngoscope combined with an A-scope in certain inter-hospital settings. So these currencies come up, and I think we're really lucky in pre-hospital and retrieval medicine, because in essence, we've only got a team of two. And I hear of Jane talking about trying to get a whole operating theatre to work together and deal with non-technical skills. And Chris is trying to organise the whole emergency department. And yet we're just a team of two. So I think it's a lot easier for us to find the opportunities to train together. If you've got two people working on a shift, there's going to be some downtime during the day. There's that opportunity. We've got our training kit right next door, so it's right there. All we have to do is go pick it up, bring it back, and we can actually effect the training. And so I think we're actually really, really lucky that we work in that environment. And so training together and this currency refresher is really easy for us.
So you have a bit of ease of access. That's good. Yep. Sorry.
Yeah. No, I was just, I think the second part of the question is the hard bit. How does that transport into a hospital environment? I think in there lies a big challenge, because you've got maybe more complex teams and less ease of opportunity. I don't notice much downtime when I'm doing my anaesthetic lists in the way that I do when I've got a pre-hospital shift. So yeah, I think really challenging to see how you could just slip that into the hospital setting.
Right. So we don't have the luxury of time, maybe that you do, but what you have managed is to subject a bunch of experienced clinicians, because let's remember the people you're dealing with here are experienced airway practitioners, and you've managed to get those people to agree to mandatory training, which is something that we're going to talk about a bit later. So Nick, have we got any questions coming in from the audience?
We have had a bit of a lull in questions, but I'll just take this opportunity to actually, I think my microphone's not quite going. We good? Yep. Okay, so we've had a bit of a lull in questions, John, but we might, I've got something I just wanted to raise with everyone that I thought might be interesting. And it relates to another team tool, which is the Vortex approach. Now, I know all of you think
sorry, I've never heard of that.
I know all of you think of the Vortex approach as this innovative cognitive aid that has revolutionized airway management. And sure, it is that, all that, and much, much more. But what if the Vortex was also a game show? So I asked our producer to give us something that really captured the elegant simplicity of the Vortex approach, and I have to say that, perfect dismount. That was all class. What I want to do, the debate is a conference staple, but it tends to drag a bit, and I thought we could move through some topics a bit quickly. So the rules of this game are, I'm going to give you some classic Airway debate topics and a few other ones that I've thrown in of my own. We're going to have 4 minutes on the clock, if we can just bring up the timer. It's a binary format. For each question, I will present you with 2 answers. You may only choose one of these. No, maybe, if, but. If you say anything but one of those 2 answers, you will hear this noise. It's complete silence.
Can we sign up for this?
Sorry?
Okay. Can I get a buzzer? I feel I need a buzzer.
You just get buzzed out if you don't do what I say. That's the way it works, Claire. Okay. I want you, when I ask you general questions, if I don't give you a specific context, I want you to answer for all patients, not just the ones you care for in your area of practice. And the one with the highest score at the end wins. Okay? Now, you might be wondering...
How exactly are you allocating these points, Nick?
Sorry?
How exactly are you allocating points?
I know it is an opinion-based thing, but basically we will match. If you match with my opinion, then we say you have the right opinion and you get a point. Okay. Are we ready to play into the Vortex? Okay, so what I'm going to do, panel, is Claire, Jane, Kirsten, Chris, John, I'm going to ask the question, and I just want you to give me one of the 2 answers, just so we can get through as many questions as quickly as possible. Okay. We'll do a practice question before we start. You're performing a rapid sequence intubation on a bleeding hemodynamically unstable patient. Your induction agent of choice is propofol or ketamine. Claire.
Ketamine.
Jane.
Don't care.
Sorry?
Don't care.
Buzzer out. Yep, thank you. Kirsten.
Propofol.
Chris.
Ketamine.
John.
Ketamine.
Beautiful. That's how we play, but faster than that, please. Don't wait for me to say their name. When the last person answers, just move on. Okay, we're ready. And start the clock. Rapid sequence intubation in a small bowel obstruction. Rock or sucks? Claire. Next.
Rock.
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 Okay. Same patient. Are you going to use cricoid pressure? Claire.
Yes.
Maybe.
Yes.
Buzzer out. Jane. Jane's getting negative points. Kirsten.
Yes.
Yes. Chris.
No.
John.
No.
Okay. Same patient. Same patient. Oh, sorry. The correct answer was yes. You're going to use cricoid. Same patient. As you're performing laryngoscopy, the pharynx starts to fill with regurgitated gastric content. Do you apply cricoid pressure now?
No.
Claire.
No.
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 Okay. The correct answer was you do what you did before the regurgitation came up, which I think everyone did. So, should we fully pre-oxygenate every patient whenever feasible? Yes or no?
Yes.
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 Beautiful. Should we perform apneic oxygenation on every patient whenever feasible?
Yes.
Oh, sorry. Pre-ox was right for everyone. Yep.
Yes.
Okay, the correct answer was no for that one. All things being equal and assuming easy access to all equipment, should we use high flow humidified nasal oxygen or a face mask to pre-oxygenate? Claire?
Oh, I really don't mind.
Buzz out. Jane?
I love high flow.
I'll take that as an answer. Kirsten?
High flow.
Chris?
Face mask.
John?
Face mask. Face mask.
The correct answer was face mask. Terminology question. You're in a can't intubate, can't oxygenate situation. Do you just say to your team, we need to perform e-phoner or neck rescue? Claire?
Oh, I don't think they'd understand
Jane?
either.
Jane?
I refer to the shared mental model in our airway briefing to use a terminology that's agreed.
Yeah,
But
love it.
still not one of the answers. Buzzer out.
Best one.
Kirsten?
I don't think Kiwis are familiar with either of your
Chris?
options.
Neck rescue.
John?
Neck rescue.
Okay, excellent. Correct answer was, of course, neck rescue. Technique question. You're performing neck rescue. Cannula or scalpel? Claire?
Scalpel.
Sorry, scalpel. Yeah, scalpel bougie.
Just try to keep up with the changes. Kirsten?
Scalpel.
Chris?
Scalpel.
John?
Scalpel. Scalpel.
Beautiful.
Scalpel.
Correct answer was scalpel. Photo question. Can we put up the photo? Okay. This is an anaesthetist making an attempt at face mask ventilation. You can see he's performing vice grip with 2 hands with his assistant ventilating. There's no entitled CO2 trace, no chest rise or fall. There's a big leak around the mask. The capnograph is working. There's not a problem with the capnograph, but he's got no CO2 trace. He's convinced the airway is obstructed, but the SATs remain 100% because he's fully pre-oxygenated the patient. Question, is oxygenation adequate? Yes or no? Claire?
Won't be in a minute.
Yes or no? Buzzer out. Jane?
No.
No. John, no.
No.
The correct answer was no. Same question. Is the patient in the green zone or the vortex? Claire?
Oh, I needed a terminology brief before we started. Sorry.
That is true. I will allow that as an answer. You can't
Vortex.
use bizarre terminology without without being educated. Who am I talking to next? Jane?
Vortex, in the vortex.
Excellent. Kirsten?
Vortex.
Chris?
Yeah, not in the green zone. Vortex.
John?
Vortex.
Correct answer was vortex, and we're out of time, and that is the end of the first ever edition of Into the Vortex. We got any questions come through? Will Rosenblatt's voice has voted for scalpel.
Can I just say there was a great comment that came through that said that last 5 minutes was a bit like being one of your trainees, Nick.
Oh no, that's much worse. That's much worse, John. I think we need to, sorry, what was that, Jane?
Can I ask you a question, Nick? You've put us on the spot.
Sorry?
You've put us on the spot. Can I ask you a question?
You certainly may.
What's your strategy for getting a shared terminology across interprofessional groups?
I'm publishing universal airway guidelines that apply to every discipline in every country on the planet.
The implementation strategy.
And we've got an implementation strategy. There will be an education program goes with that. But in a more serious level, I mean that is serious. But at a local level, we would never implement the Vortex without training people in that weird language, because otherwise it causes much more harm than good. But I think the clarity that comes from that terminology really helps people. But your point is well taken. You absolutely need to make sure that whatever terminology you need use is clearly understood by the whole team. John, I think we've got to wrap up. I think we need to do panel goodbye first and then summary for practical reasons.
Okay. Well, I'd like to thank the panel. Thanks very much. And I'm sorry we sprung that last bit on you without any warning.
And on you too.
That's okay.
Thank you.
So I think we'll do some take-homes, shall we, from that session? So what we've learned in that session and from the videos that were accompanied, which you can find in the resources page, that technical skills and non-technical skills need to be given equal emphasis and taught together. We've looked at a model for training for some of those behaviours and techniques called the Big Five. We've learned how this can be achieved from interprofessional training courses and also a workplace-based program that Claire told us about. If you're going to train airway management, you've got to train in intact teams. It's got to be interprofessional, if at all possible. We've heard about the concept of the Airway Ally and upskilling airway assistants who are occasional operators. And we didn't talk too much about VL, but using VL can improve team performance. It turns the intubation from me to we, and that's one I really like that concept. So, Crimesy, can we put the poll result up? Is that possible?
I have a feeling that we didn't get. We're either no one voted or we're having trouble accessing it at the moment. So the poll result is a no-go, I'm afraid. Okay,
fair enough. Well, my impression would be that not many people have access to regular intact teams training. Nick, we were talking earlier a bit about your team kind of training that you do with your novice anaesthetists at Monash, and I know that that's happening in a couple of hospitals around where you are. Can you describe that to us? What are the components of that?
Yeah, so we have anaesthetic residents come in at a third-year postgraduate level, as not on the training program, but as a sort of rehearsal to get, basically to see if we like them and get a feel if they like the specialty. So it's just a year of critical care, mostly anaesthetics, but they rotate out to some ICU. And about 15 years ago, I put together a program whereby they do, at one of our campuses, they do some after hours stuff where they're the most senior person on call, which is quite a change for them in terms of having to, you know, liaise with the consultant primarily rather than going through a registrar overnight, and also suddenly having the moniker of anaesthetic resident on them and having to run codes and be first on site is often a new thing for them. So we thought it was a bit unfair, those and a few other things that are new to them, a bit unfair to just put them out on the wards without any training. So their first week of that year, they're rostered to be completely offline. And they come to the simulation centre at Monash Simulation, and they do a week-long session of both skills and team training, really focused on the sorts of skills that they will need to use after hours when they're unsupervised. So we don't teach them laryngoscopy and intubation there, because we don't expect them to do that on their own anyway. And at the start of the year, and they'll learn that all in theatre. But things like running cardiac arrest, performing basic face mask ventilation, putting in a supraglottic airway, principles around the vortex and just decision making, and some other specific anaesthetic things in terms of epidural management and troubleshooting. And also non-technical things like, as I mentioned, how to talk to a consultant, you know, practicing talking to a consultant on the phone overnight, because obviously often that's quite intimidating to try and call them. So we've been running that for about 15 years. And then at the end of that week, we hope they've got a little bit of a feel for the stuff they have to do after hours. And then they come back once a month for a half-day session of anaesthetic, really increasingly high-fidelity simulation training, which is multi-professional, so we get some of the nurses involved in that. And that's been running for a long time now at Monash. We find it a really useful way to get sort of in a whole sort of 12-month induction program for our anaesthetic residents.
Yeah, I really like that that kind of scaffolded approach where you've identified that one little skill, just that example of the phone call to the boss. Because as you said, you know, a lot of these guys are used to talking to registrars rather than going straight to the consultant, and so that just getting them to sim phone calls to the boss, that's just a little micro skill that you can isolate and teach. I love that. So I think we're going to a break now.
Yep, so we're just going to step out to a quick break, are we? And we will be back after these messages. Don't go anywhere.